don't know if you can hear me. I'm on an iPhone now, not on my laptop. So I'm not sure how I can actually activate the screen for the questions. Can you hear me?
Yeah.
Ah, good. Okay, because I can't see anybody on an iPhone. You need glasses. Right.
Yeah, we can hear you, Hugh.
Oh, Jill, I can see. Okay. Are we putting? We're dealing with some questions here, but have you any things which have occurred during Dominique's presentation that you'd like to ask? I know we've got specific questions we want to go to. Yeah, Jill. I can see your hand, but I've got I've no idea how to let you in or whatever. So
it's all right. We can just speak. Can I ask Dominique just to explain again the time to complete coverage estimation? I mean, I've read the paper and I've listened to you, and I'm still not quite sure I understand it. Could you do that again just to help understand? Thanks.
Yeah, thank you for the question. In order to prevent interferences or Larsen effect, I would like everyone to cut down the microphone so it will make more easy. Dominique is a complex person, and he always shows up with complex IDs and measurements of all sorts. So let me, with a show of hands, try to explain simply. This is the surface of the scalp, right? There is nothing that you can see except for a single hair popping up, right? So if I measure the presence or absence of that hair, it is one hair. I measure the thickness. I measure the length. And 2 days later, I measure again the thickness and the length. If it's an anagen hair, there will be one hair, thickness by length, in 48 hours. I know precisely how much time between the two photos. Now, if we talk about 4, 5, 200 hairs, we can sum up the amount of hair that is being produced per 48 hours. If you multiply that, say by 2 days is by 15, you will get the amount of area that is being covered by the growing hair. And so you say, for example, in our controls, it would take around 20 days if you shave the area completely to have an almost complete coverage of this 1 centimeter square. That's how we create the parameter. Clear?
does that help you, Jill?
Yeah, that's clear. Thank you very much, Dominique. I think it's a useful parameter. I've been recently looking at some bald heads. So now you've explained that it's a kind of an estimation of what it would take to go from completely shaved to completely covered based on density, diameter, then yeah, that makes sense. And presume, does it take into account hair color and also gray hairs, white hairs, and also does it take into account things like the orientation of the hair as it comes out of the head? So some hairs lie flat and some hairs stick out. So I know your coverage is a kind of visual representation, but the time to complete coverage is a mathematical one. So it's just to integrate those two things.
Actually, that's a very good question. I was awarded a prize by the European Academy of Dermatology in 1991 in Athens. I was really surprised because the only thing I published was use a glass slide, put some oil and recline the hair on the surface of the skin. Now, if you're very powerful in terms of mathematics, you will realize that this is the sinus or cosinus of this little hair is about 30 to 50%, depend how long it is, depending on the angle. So we resolved this problem just by making the hair lying flat on the skin. Another question that we resolved was the visibility of hair. And this relates to a paper by Hugh, Rushton, Bernadette Devroye, myself. We were slightly lower than you plugging out all the hair from an area. And we realized that the very lightly pigmented hair, even not the white hair, but if the diameter is thin and the load of pigment is low, the light is so strong, it crosses the hair, it bounces back, and you don't see. So the measurements were not appropriate. That was the beginning of the years 90. So we decided to apply the hair dye, and other people who copied the phototrichogram technology, they said, it's obvious you have to dye the hair. And you say, how obvious was it 10 years ago? And then you get no answer. So the idea was, I would say, clever, a little bit difficult for a dermatologist to apply paraphenylene diamine, thinking about allergies and things like. It's extremely rare. We do not induce allergy with this type of procedure, but sometimes if people forget to tell you about they are allergic to hair dyes, it can be a bit of a problem. So that's how we got through with the thinness and finally measure in an exhaustive. That's one of the keywords of this paper. It's exhaustive. It means we measure not only what I say is important hair, we measure all the hair, even if it is less important in terms of coverage. But the less important has a high diagnostic value. Hairs, say more than 15 per centimeter square, that have less than 20 micrometer in thickness is an indication of the beginning regressing process leading to baldness in the future. Thank you.
Dominic, did you look at the issues that might be encountered by looking at dark hair on dark skin? So when you're looking at different ethnic groups, how are you accounting for that? I mean, I know the white hair and grey hair on a white scalp is the other end of the spectrum. So did you, I mean, I missed all of the first off, I couldn't get into it. Obviously I've read the paper and stuff, but what was your personal experience with the extremes of the spectrum of hair color and skin color?
Yeah, thank you for this question. I have a number of patients from African origin. And I said to myself, not like Louis Armstrong, and I said to myself, what a wonderful world. I said, how stupid are you to put a dye on top of the hair in this person? And it's absolutely astonishing. You can see the smallest hair fiber on the black background because the background in an African person has a pattern. And the hair is really like a line that crosses this pattern. So you can certainly identify the hair. I don't know if computers can do that automatically, but I can, as a human being or as a technician, look at the scalp with this technology and identify miniaturized hair, no problem. White hair is exactly the same. The problem with white hair is because the dye is like a paint on the surface, you have a kind of rectangle. So the dye does not enter the hair fiber. So you in the process of, that's why humans, I think, are still required in qualifying the phototrichogram technique. You will have two lines with nothing in the middle. And that's one of the major problems of trichoscan, because he will consider there are two hairs instead of one. I thank you. I guess that you see eventually Professor Torello Lotti asking a question.
No, I can't.
Yes, Dominique,
Dominic.
First of all, I would like to yes.
Yeah,
Can
carry
I
on.
speak?
Yes, absolutely.
Okay. Dominic, first of all, I would like to thank you for publishing such a outstanding paper in this issue of PAR journal, which I am guest editing, and I would never imagine of getting such a useful and innovative information. I have a couple of comments more than questions. The first one is that in the conclusion of your paper, you state that your studies support negative conclusion. That means that rare abrupt transformation within one cycle of terminal hair follicles into miniaturized one is the issue. So in other terms, there is little hope, and we trust totally what you have demonstrated to go on this way. The second issue, which is even more intriguing, is that you mention a sentence of Andrew Messenger that this will require a substantial amount of creativity in terms of methodological approaches and drug discovery. My question to you, after this step of giant, you have been a giant in publishing this paper. This step is really very innovative. After this, what do you see behind the corner of new methodological approaches and drug discovery? In which direction? Thank you very much.
Dominic, let me take the first question, reply to that, if you're okay. Yes? Can you hear me?
The answer is yes.
Yes, I can hear you well.
Right, so let's deal with the whiting issue. One of the problems that you have is that one of the first things that happen in male pattern hair loss is a shortening of the anagen duration. And we measure that by looking at telogen hairs less than 3 centimeters in length. And what happens is that that is the very first change before you have any diameter changes. Now, if you can imagine that with a resting phase of 3 months and 3 months growth, you could get 3 or 4 hair cycles, which could represent 10 years in a normal anagen phase. So what you're doing is you're speeding up the process of where the miniaturization can then take place. And so the idea that if you watch somebody over 12 months or 18 months, you could actually see the vellus hair formed. But when you actually take hairs out and measure them, you could actually look at the different lengths that are going on. So this idea that you can transform a vellus hair in one cycle, physiologically, I can't see how it could be done. But you can explain it by multiple rapid transformations of anagen to telogen, and therefore it appears that it's transformed over one cycle. We do know from work we've published in 2016, you can't reverse a vellus different from a true vellus hair, which is not attached to the erectopillar muscle, which the vellus-like hairs are. Does that sort of answer the question?
Well, I will answer.
Yes, thank you.
Yeah, so I will answer looking from a slightly different angle. If you remember the comparative view of the 2 scalp samples in the very beginning of the presentation, you have seen in the balding scalp, there were a lot of little hairs, but still there was a thick terminal follicle. If that biopsy would be sectioned according to David Whiting's or Headington's method, you would say that's a nice terminal follicle. But in terms of production, probably it will only produce a 1 or 2 centimeter long hair because the hair cycle is very short. It will enter into telogen, and after 3-4 months, it will be shed and probably recycle again, even with the same diameter in even a shorter production phase. But the major problem with histology and scalp biopsy is that it is extremely difficult to derive a precise dynamic phenomenon. You may remember in the years 70 and early 80s, I was really interested in cell cycle measurements on scalp biopsies. I was interested in movement of scabies mites in the skin. And I resolved the question saying, it's just impossible. It is maybe immoral to do thousands of biopsies to measure a dynamic phenomenon. So Dominique, you have to do your homework. That's what I did between 1980 and 2020. Now, dear Torello, you asked me, you asked me to tell the future. So I don't have a crystal globe to tell what you should do with your students, your fellows, etc. I think there are promising approaches like optical coherence tomography that will improve, dual laser confocal microscopy. You know, these tools, they cost a hell of a lot of money, which is one thing. So a dual confocal microscope, you're around €1 million. I've been laying a full day with my hand and arms because I grafted some follicles here on my forearm. And after 8 hours, you understand? 3 people, 1 technician, 2 engineers, and myself, 8 hours. At last, we have a view of down about 150 micrometer in the skin. So there will be a hell of a distance and a lot of money to be injected in making more progress. But I'm part of the future to help and try to reconsider what approaches might be useful. Thank you. Now the drugs, the one cycle is no problem. And then messenger about the creative methods I did answer. Maybe one little gem to add to your question, Torello, is when hair is regrowing with a combination of finasteride and minoxidil, the growth rate is unchanged. The duration of growth will increase. The speed of re-entering anagen will be increased, so the lag phase will be shorter. But the growth rate of that follicle apparently seems to be irreversibly affected. It remains a slow growing, even though it is a thick hair fiber. That's something also absolutely original and surprising from my studies. Thank you.
Thank you very much, Dominique. Thank you. Thank you very much.
Yes, unfortunately, I don't have any names or anybody who wants to come in. Does anybody particularly want to come in at the moment? There's a hand up, but I can't see any names. So yes, come in, but tell us who you are. I'm sorry about this technological problem. I have the questions that people have sent in. So is there anybody who wants to ask anything else? Because we could go on to the use of this technique. I saw one of the questions, which basically was looking at follicular counts in hair transplant surgery and the use of it for predicting outcomes in individuals who are seeking hair transplants. Can't remember who, because I don't have all the questions. Who actually asked that? Is that?
I've done this question. I've done this question.
Okay.
Piero Tesauro.
Okay. So can you pull in people? There was a hand up, but I couldn't. It didn't tell me who it was, I'm afraid.
I'm sorry.
Which questions have we actually covered? Is there anybody who had raised a question or asked further questions that they want to sort of bring to the group?
No.
What about our Korean group and various
I think, sorry to interrupt you, I think Piero Tesauro was eventually willing to ask his question to you.
Yeah.
Yes, I have a question about the new therapy that comes out from this study, and when a patient is, when we cannot reverse a patient after a total time longer than 180 days, which kind of therapy you suggest to your patient? I was introducing my question because I'm studying the use of stromal vascular factor injection in my patient when they have no response after a normal treatment. And up now, I have good results in my experience, especially on aging scalp. So I think that I'm not sure, but the best response that I have up to now is on aging patient, that probably this change of message between the hypodermal layer and the follicles are extremely important, and probably this kind of therapy will make something to restart a normal change of message. And I don't know if I can share the screen for a moment. Can I share the screen? So my idea is that I have this kind of patient that has a negative outcome after 2 operations, and I did a treatment with the stromal vascular factor, and just with this treatment, I revert the miniaturization of the previous implanted follicles. This is a view from the side where you can see that normally you have more hair mass on the head of the patient. Of course, I've treated scars and I have good results after the transplant, much better than before. And I have treated patients before the transplant, like this one, where I treat the scalp. He had 2 previous negative outcomes, and prior to another operation, I treat the scalp, and obviously the change on the scalp is extremely evident. So the question to you is, do you think this could be one of the way to treat patients with not responsive therapy? Thank you.
Dominic, do you want to come in there?
Yes, thank you for this question. I have no personal experience, I would say, with kind of biologic restoration of function. We probably know that there are some inhibitors or growth factors that are lacking in the balding scalp. So any approach that would be ethically acceptable may be worth a trial. The point is always to have the appropriate controls, which in matter of scalp hair growth is a critical question, because the people don't like it. They consider themselves like, I'm a laboratory animal, where in fact they might eventually be promoted as being part of the growth of knowledge and science, which is one thing. The other thing is, if we begin to play with stem cells, there is a huge interest from the medical community in various segments. I may draw the attention to the fact that we don't know exactly what we're doing. What are those stem cells becoming once they are launched into the dermis? And some health organizations in Europe, maybe in other continents as well, have warnings that these cells might eventually turn into tumors, and we have no idea about what we're doing. Last comment, in this type of approach, we know from the 50 or 70 years now that we perform scalp hair transplantation, that if you take the terminal end organ, which is the hair follicle, I don't know of any tumor that would have been induced by injecting a hair follicle in its dermal sheet surrounding that will move up and down during the various cycling, and that would eventually end up in becoming a tumor. So it would be great to have the opinion of people more acquainted with the transplantation technologies to answer eventually more precisely that question. Thank you.
Thank you very much.
We do have some attendees who've actually got some hair transplant experience. Have they any comments on this aspect? Yeah, I was interested when you said that you mentioned when you performed this that you converted a vellus hair, but my problem is that I'm not sure if it actually was a vellus hair in the true definition, which is a hair that's less than 40 microns in diameter, less than 30 millimeters in length. And it would be interesting to actually look at what was occurring. So if we did like, the unitary trichogram, or we did a analysis of the hairs on the individuals which weren't responded, and then take the hair out on a response, you could then characterize the hair diameter, the hair length, and also the hair density. And you get an idea whether in fact it was actually vellus-like hair which has been altered, or it's unlikely to be a true vellus hair because the number of them in per square centimeter is not very high. But there is a process where the miniaturization is rescuable. So we haven't quite yet got it, but we think that hairs between 40 and 50 microns, and we've got some work going on which will be coming out soon in a paper that we're publishing, that looks that you can actually rescue hairs to a certain point. So it could be argued that the actual biopsy not the biopsy, but the transplant you're taking may have contained one of those hairs, and the nutrients and whatever you're putting in has actually just activated them, and you've got a growth. But that could be all measured if you had these individuals who hadn't responded. So it's just a thought off the top of my head with that. All I know is that we did some work back in '86 with Walter Unger, and we took the balding follicles and we reinserted them into the occipital end to see, once we'd removed all the fat and everything else, right, would the inhibition that was stopping those hairs grow lie underneath the dermal papilla, for instance. And unfortunately, we couldn't get any hairs to grow because they got infected. But it was an interesting idea. They just sunk too deeply into the whole. This is before follicular units were developed. But we couldn't grow any hair, not because we didn't have the right technique, we just had infection, which stopped it. I don't know whether that's any help to anybody. Anybody else got comments?
May I make a comment on that, Hugh?
Yeah, fine.
A comment, maybe an advice to Piero Tesauro from Italy. Actually, my friend, Hugh Rushton, and myself, we are fighting since about 33 years, but we still are good friends. That's what friends are for. It's for fighting and remain trustable. Actually, I would not pluck out the hair from those poor individuals who have a bad response. But if you have some time, you would like to make phototrichograms every week, for example, on those hair, in order to see the dynamics. Now, why every week? Because we were very surprised to see in 1 month, if we have 4 weekly phototrichograms, it's absolutely astonishing how fast cycling can go on. So there is a manuscript published in one of my books where we have that picture. If you would like it, I can send it to you. But in a small field, you can see all passages from telogen into exogen, from no hair into beginning of anagen, regression, anagen, catagen, telogen. It's absolutely astonishing. So make a little movie, 2 photographs, close up, high magnification. Of course, it's a budget in terms of time, but it's worth answering your question. Does it work? Does it reverse? You will get the answer at the end. Thank you.
Thank you,
Can
Dominic.
I just say also, Dominique, that I've seen that on the underarm. When I've looked at phototrichograms in the underarm, the speed at which you get the hair cycle is amazing. So it is a phenomenon. And I think we're rather used to thinking of the head as being rather slow cycling and the body hair being rather slow cycling, i.e. static in intelligent. But actually there are regions on the body where the cycle is very fast. And I think we should remember that in phototrichograms, because the follicle product, the hair, is what you see in a photograph, but the product of that follicle is not the same product 1 month to the next because the cycle is so fast.
You're exactly pointing to what astronomers understood a couple of 100 years ago. It's the pace of your measurement. And I see myself a little bit like Johannes Kepler and Tycho Brahe fighting. Brahe was just recording all sorts of measurements, but he had a theory in his head that the sun was turning around the world. And the observations did not fit his theory. And after 3 years, the Kepler measurements, so it took him 3 years just to calculate the orbital of Mars. It was not a circle, it was an ellipse. Today, we are really getting to the point, making a photograph every month. We think it was fantastic, but if you do it every week, you see a totally different world. That's it. Thank you.
Can I also say that I think the nano hairs that you observe are very interesting because they probably reflect a combination of very small follicular hairs, but also the very fine tips of newly emerging anagen hairs. And I've often thought that if somebody could come up with a way of scoring those newly fine tips emerging from the follicle orifice, from the infundibulum, that would be the most sensitive method and the quickest method for clinically evaluating the effect of a hair growth treatment. And I've tried in the lab to do things like dye them, stain them with particular fluorescent dyes, use fluorescence microscopy. I think you could probably do it using confocal scanning laser microscopy, but that's time consuming and quite difficult. But a method of detecting new tips would be, and doing it over every week, like you say, I think would be a very rapid hair growth clinical evaluation measurement tool that you could use using digital photography. So maybe artificial intelligence and machine learning is going to give us that in the future.
Okay, two comments for you, Jill, if I may, Mr. Chairman.
Yeah, fire.
Okay. So we have the experience of a fine tip that grows at a high speed is definitely coming from a terminal type follicle down there, 4 or 5 millimeters below. So the beginning of anagen is, wow, I would need a highly sophisticated model like this one. So the tip, if this is a thick hair root, deeply set terminal follicle, your thin tip will grow 0.3 and something micrometer per day. If it's really from a very fine follicle, atrophic, it will grow very slowly. And after maybe a couple of weeks, it will stop. So if you do it weekly and you measure the growth rate appropriately, you have the answer to your question. Now, any other methodology will need a number of validation trials. I am a little bit sad because I've seen confocal compared with Tricoscan, compared with this and that. And the people say it's all great. So you really have to see exactly what you're looking for. And once you analyze, it is your intelligence that you can transfer to the computer and learn the computer how to do things. And if it does not do things properly, he can be trained, the computer can be trained to augment his capacity, like we humans. During the last 40 years, I learned a lot of things about hair. So a computer can do it fast, can do it nicely, can do it in a very repeatable way. But if he is wrong, although artificially intelligent, he is wrong. That's the point. So the images are available, the counts and gross productivity are available, and it would be a nice moment to match these two together and come up with artificial intelligence for scoring. Thank you.
May I ask you something, Dominique? I'm Piero Tesauro. Just it's a simple question. We lack of time every single day, and all the collection is extremely difficult. Did you never try a method to give this collection to the only person that has time, and the only person in my mind is the patient? Did you never try to teach the most clever between your patient to do something that can help your research?
Well,
Do you want me to,
excuse me, you want me to answer?
let me just, Dominic, just hang on a second, because it's an interesting question. Do you remember many years ago, in the early days before we had your methodology in the unitary trichogram, people used to collect hairs in a basin. And I've seen some really interesting work with that, particularly in Italy. They like this. But one of the problems that you would have is, in order to collect things. Now, coming back to your daily or alternate day, the hair's turning over. So one of the things that I thought of with the washing technique, i.e., I think it was half a day back, they used to get his to bring in all their hair samples, and not only that, count them. But what was interesting is that if, for instance, you did the wash technique and you actually had a washing period a week before and collected it every day, you'd remove the exogen hairs and you really would be looking at the telogen hairs which have been released. Now, if you've got, say, a linen collection thing, and you then picked out the telogen hairs less than, that were 3 centimeters long, because they're all telogen, you could actually predict if that person's male pattern hair loss is progressive. And that's, the patient could actually bring those in and then lay those hairs out, because in a day, there wouldn't be that many, but you would actually have a look at the telogen proportion, which you could, because in a phototrichogram, the telogen proportion doesn't move, but when they wash it out, it does. Okay, go on. That was my bit for doing collections on a daily basis with a wash test and not waiting 7 days, which practically I couldn't get any patient not to wash their hair for 7 days. But getting to do every day with a washing period a week before might make a nice, interesting project.
Yes, I agree with you, you and Piero Tesauro. The problem of collection is, again, the key word is exhaustive. We are not really sure about collecting absolute all and every single hair that is being shed, because they move around all day long. So standardization is a key word in that process. And I think the patient can help. The other way patient can help is to have an appreciation by self-perception. So we have seen genomic studies with 50,000 people involved. So the budget must not be 1,000 euro, but a little bit more. And the conclusion is correlation between certain genes expression and the severity of the disease. But the point is that the perception in our hands, if you show the patients these cartoons that you've seen, between 50 and 80% are underestimating the severity of their hair loss. So running big studies with sophisticated genomic analysis and not using an appropriate technology in the hands of the people participating to the study is, I think, a sad situation. So again, to come back to Jill's suggestion that artificial intelligence could help, I would certainly say, yes, it could help, provided that the intelligence is really intelligent. Thank you.
Well, just coming, Dominic, just coming back to the daily shedding, if you use the conditioner to remove the interfiber friction, through the day, you would hardly have any hair loss. So if the person did the same thing, this is back to standardization. This is what we did when we did the original work on the unit area tracker. We controlled everything. The number of times they comb their hair, the number of times that they wash their hair in a month leading up to it. There were lots of things to control. But it could be done quite simply by just using a conditioner, one application of shampoo, washed every day, and then just collect all the hairs that come out on that shampoo wash in a fairly big linen type or collection material, and then it could be looked at. It's just a thought. I've thought about that for a long time, which is very interesting, that the patient involvement would help the clinician. I'm not sure they could count it, and that's where Jill's is. If you could then lay out these hairs, perhaps on a slide, and just the artificial could go down, measure. They're all telogen hairs, so all we're looking at is a hair that's less than 3 centimeters long in relation to the total population that's being shed. So you could combine the artificial intelligence with the patient collecting it. You might need a technician just to lay it out and then run it through that. And that may be an easy way to actually measure if male pattern hair loss is progressing or is present. Just a thought.
I more or less agree. You should have a kind of vacuum comb with a vacuum cleaner, and then an analyzer telling you the thickness and the length.
Oh, yeah.
This is a development. I think, as I have a view on the screen, I think Jean Devroye was asking, and then Professor Young.
Yes, a few months ago, I was speaking with Ken Wojnik, and I asked him about cloning, and I asked him about the fact that we are not talking a lot about it. And he said, yes, it's really difficult. And I said, what is the future? And he said, probably we are working more on medication that should revert the miniaturization. But it seems that your study shown that it's absolutely impossible to do that, or it's not very frequent. So what do you think about it? Is it possible? Is it something that could happen or not?
Well, I thank you, Jean, for this question. I will answer you. I will answer. Yes. Actually, the stimulation, the induction of regrowth, and now there are many different methods that point to the fact it is probably, with the existing compounds, it is probably not reversible. At least when the atrophy is morphologically, structurally, and functionally present. But there is a way in between terminal follicles losing their potential. You can certainly do it with finasteride and minoxidil. It's very clear. You induce longer cycle, thickening of the hair, not really improved rate of growth, but prolongation of the anagen phase and shortening of the lag phase in between. So you can do something when the follicle is on its way towards regression. Now, it is not excluded that future compounds that will address other aspects of regression might induce regrowth from miniaturized follicles. I don't know where the magic will be, but we tried at least one compound during the last 20 years that would increase the rate of growth within 2 weeks of application. Not only 2 weeks of application, but it was a kind of long-lasting effect. So you apply the compound during 2 weeks, you have an acceleration of the rate of growth, you stop the application and the rate of growth remain accelerated for the next 2 months. Now the point is, this is big business. American company raised funds and then they stopped the research and development program. They went on for commercial selling of antibiotics. It's a nightmare to be involved in hair growth research, to put your hands on something absolutely fantastic that would come in complement with other compounds and certainly raise better hair growth, and then they stop the development. So I can't help in that. Reversing is the future, and certainly better prevention of regression. Thank you, Jean, for your question.
Dominic, can we point him to the 2016 paper that we published in Clinical in Experimental Dermatology, which looked at all of the treatments over the 25 years, and we actually followed the absolute values of vellus-like hairs and showed that we didn't have any change whatsoever. And that's 2016. We send a reprint.
Well, I think we will not enter into that discussion because it's a conference on itself, and maybe the people will be interested in receiving the reprint. That's a good idea, and we can correspond later on. Thank you.
Dr. Dominic.
Okay.
And China. Yeah, I think I may share the same very common questions with us doctors such as Piero, because for our hair doctors in the clinic, I think a quick and easy check of the hair growth is very important for us, and also for the patients. Since the confirmation of the hair regrowth is the encouragement is not only for the patients and also for doctors, because the treatment for the hairs is a long-term treatment. Maybe it lasts for several months and a half year. So we need such encouragement. Your method for SCS, the scalp coverage scoring, is I think it's very reasonable, and divided the scalp in several separate areas, and we get the general impression of the hair growth. But anyway, I think it really takes time and some energy to get results. So for clinical work, and maybe it's not so easy and quick for us to give the patients the confidence, the confidence. And so maybe with the camera, with the computer, so maybe we can do it easily and quickly in the future. Do you think, for example, with our knowledge and with technology, we can have such a instrument or some software to help us to do this with a high efficiency?
If you allow me to answer that comment and question.
Comments, okay.
Yeah, actually, you've seen the Belgian wafer. Wafer is a little square about 1 centimeter, but it can be 3 millimeters. And I choose for my observation of the scalp a square that is about 4 centimeter by 4 centimeter. Now, if you remind the definition by Hugh Rushton about a vellus hair, that would not be cosmetically representative. It means a hair that is shorter than 4 centimeters. If you comb it in between, it's 2 centimeters and 2 centimeters, it could help a little bit in coverage, but it would not be performing very well. So the chance by 2 different visions encounter more or less a limit of 2 centimeters, 3 centimeters, 4 centimeters to be an appropriate hair in terms of coverage. Now, this is an affair of chance. I was lucky to have chosen in between the 100,000 range of units or pixels of informations. I choose something that would be clinically relevant. And I think the people are happy with this.
And
it's also something useful for the clinician. So please go
yeah,
ahead.
yeah, as you mentioned that when we choose a small area with 2 or 3 centimeters, square centimeters, we can inspect the specific area again. And yes, we have tried to do this. So the one question is how to locate this specific area. Since we use cameras or we use the trachogram to take the picture every time, do you think it's necessary to locate with a tattoo or something like that?
I'll answer that. When we are in the context of a clinical trial, we decide beforehand to monitor a population of hair follicles in a given area. So in that situation, it's mandatory over a long term, say 1 year, 2 years, 3 years follow-up, to have a tattoo to make sure you always come back to the same site. And you get rid of follicles. Sometimes your camera is a little bit to the left, a little bit to the right. And at the end, if you have a pool of say 0.6, 0.7, 0.8 millimeter diameter, that's fine. You have enough follicles to do a high-tech follow-up study. We use red tattoo because it looks a little bit like an angioma and the people are not very unhappy with that. I had about 40 tattoos on my scalp to monitor different technologies. And the one used by Merck was a big tattoo, like in a tattoo shop, and you go with a machine, and then you have a spot about 3-4 millimeter diameter, black ink. The point is that the hair does not show up very nicely against the black background. So a difference from the black African skin. So I always place the tattoo in the periphery. So 3 points will give you an area. And for our personal use, we always place 2 points towards the frontal hairline and 1 point to the back. So if your technician would change, taking the picture one way or another, you will get mixed up just looking at the hair. So if you have your tattoo in the image, it's always 2 points in the front, 1 point in the back. Just a trick.
Okay. And you use tattoo to mark the specific area in your research work or your common clinical work for
Only
every
in
patient?
research. Oh, no, not in every patient. Only research project.
Yeah. I may have such a dilemma from time to time that yes, I really need to mark the specific area for every patient so I can give the evaluation, give the estimation. Oh yeah, how about the hair regrowth? But it's very hard for me to mark the hair actually. So it's a problem.
To have very small tattoos, we used, I think, is 0.9 gauge needles. It's like a mosquito, you know?
Yeah, yeah.
And we go several times around the opening of a hair follicle. So we have one hair in a red circle. But I have no experience on how long they would stay. So I have on my forearm is about 15 years. These little dots are still present. No problem.
Yeah, okay. Thank you. Because for some women, they like to stain their eyebrows. They may use some stain that's only lasts for half year. I think this kind of stain may this kind of ink may be a good choice for us to do this.
Yeah,
I-
very good idea. Yeah, but you have to make sure you see them before it is gone.
Yeah.
If I can comment, if I can just comment, I can tell you my experience. I'm not using tattoo, and probably because my patients are unwilling to do tattoo in my office, I try to use these glasses that comes from the eye check. I put the glasses, I put the cord, and I use the number where exactly, and I record the number. I ask the patient to take the glass in place. So it's not exactly like the tattoo, but it's quite repeatable. What's your opinion about? I know that you know this kind of system.
Well, personally, we are quite happy because we have a good technician at home. So she does it very precisely. We use the same type of glasses and measure between 17 centimeters to the back. Usually she can find, when we have the photograph, she can find the same follicle openings after a couple of months. I wouldn't say after a couple of years, because without tattoo, we did not have this experience.
Anybody else had any experience with tattooing? I remember when we were doing it in a LuJun study. This again was back in 1986. The tattoos did fade over a 6-month period. And I presume that's to do with the depth of the tattoo in terms of its placement, how far down you actually get into the epidermis, dermis, and but it did disappear, and we had to re-tattoo them every 6 months. That was in a LuJun minoxidil study with Walter Unger in 1986. But again, I'll go with Dominic. Some people don't mind having tattoos, and from a unitary trichromatic point of view, a red pen always gave me a better mark, and you could see, and it was easy to see. So red seems to do very well on photography and staying there. Don't know if anybody else has had any experiences with different tattoo bases and what they put in them. I mean, what about the micropigmentation people? They often do all heads of fairly completely bald patients. I'm not sure what the re-tattooing rate is in that particular group. Anybody, any experience in that?
I don't have, only red tattoo. There's no political meaning.
There's lots of experience of the different dyes and different diameter gauge needles that are used for micropigmentation and things like blading. And the dye is fairly permanent, because those who have it done and then want to reverse it have to go through laser dye removal. The color obviously is brown, so or a range of browns. So the distinction between the tattoo and any sort of surrounding hairs would be less prominent.
Actually, I could say something about virtual tattoo, but I have a conflict of interest here.
Where is our chairman?
Well, we don't mind conflict of interest as long as you're not compromising somebody. I've had to go and get Roger for my iPhone. So I'm back with you now. But if you feel uncomfortable speaking, then that's fine by us. But if you could make it where it's neutral, then we would be interested in hearing what you have to say.
Yeah, okay. Hubert Wansky from Tricolor. We are part of PhotoFinder World, and I feel very honored to be invited into that short group of the best experts in hair measuring in the world. So I feel really honored. Now, we developed quite recently a technology which enables you to find the same spot by what we call virtual tattoo, just by analyzing the pattern of follicular openings. And you just place the camera over the spot. The camera analyzes the pattern of follicular openings and presents you like sort of tattoos as augmented reality objects. And it's available. But again, I don't want to make it commercial here.
I think there's one issue on imaging that everybody should remember, and that is that as imaging and image analysis gets better, the able to distinguish a small change in any parameter related to hair growth will also improve, but the result for the patient won't necessarily improve because of that, because you can't convince the patient just because you've got a statistical significant result of 0.01% improvement because of your fantastic technology, measurement technology. You can't convince them that you've got a benefit. So I think it's really important whenever you're considering doing clinical evaluations that the meaningful result for the consumer or the patient is kept uppermost in your mind, and that the precision of and accuracy of any equipment is not generated to the point where you're getting better at measuring small differences which are not meaningful at all to the person whose life is being affected by their hair loss. So somehow I think speed and cost, speed of getting an answer and the cost of getting an answer being cheaper are much more important than the accuracy and the precision of doing the method.
Yeah. I don't know whether I've lost you. Sorry, yeah.
And Dr. Naki?
Yes.
Yeah, yeah, I agree with you that I think you have very good methods that use your instrument to mark the follicular openings with computer. I think it's a very good way. Yes, so I am doing something. Yes, but with cameras with my own eyes to find the openings of the follicle is really hard work and energy taking. But yes, it works sometimes from time to time. Yeah, I can find the same. I can find the same follicle openings in some in the arrangement. Yes, I can locate some area, but it's really hard work for our eyes. And I really hope your instrument, your machine can help us to do that without any damage to the patient. Yeah.
And also, not to break the research budget, do we have any idea how much these things cost? They sound great, but are they feasible and can we afford them with the budgets which we have certainly in the UK? The dermatology hair clinics have all been shut down. We don't have our national health hair research clinics anymore because the dermatologists have been diverted to go and do other, what the authorities call serious, proper medical research. I mean, we're all in hair and we know the implications of hair loss in patients, but in the general medical world, they don't think hair loss is a medical problem. So part of our job, all of us here, is to actually educate them that it's really important, and techniques which help us to get valid results that people trust are welcome. So both to find out and getting equipment and getting more people doing things is a goal that we all are looking for.
Yes, actually, we sort of, Tricolab is a hair lab of photo finder, and we sort of utilize that the fact that photo finder is used mainly for early melanoma detection. So, and it's perceived as a really serious topic, and it is really serious topic. So we sort of just implement our technology on devices which usually are already at the clinic. So it's just the software which enables these doctors to do the hair assessment additionally. So I would say, for someone who already has photo finder, the software it's not a big deal. But what Jill said, I would say that it's really critical point, and to understanding that difference between statistical significance and clinical significance, and but it also works opposite. I mean, I feel like, you know, we are sort of that in her research, but not only her research, but in clinical trials, that statistical significance is like a fetish. And sometimes there are some treatments which are very close to reach that statistical significance, but due to different response, not very stable response from patients, some medications are just thrown out, having a potential, but they haven't reached statistical significance. So, but anyway, as we play these cards, then, you know, at least our aim and goal is to not to generate fluctuations coming from measurements. So if we can reduce the fluctuations coming from measurements to something which does not influence the research, then we are at least on the side where just the response to treatment is really makes something, a final result reliable.
I'll take you back to, I'm not sure how many of you remember John Egley. You might have seen a lot of his work from the 60s and the 70s. He was my PhD examiner. And I remember him telling me in the mid-70s, he used to say, Hugh, if your patient can't see the treatment working, you might as well give up. So, and I was developing the unitarian trichogram, and I said, John, I don't want to wait 18 months to see the hair growing. I want to be able to do it within 3 or 4 months. So I think we have a combination here that Jill's right. The patients need to see it, but they have to rely on the methodology, because what happens is that I've seen quite a lot of studies, and basically the hair analysis evaluation was very questionable. And I suppose going back, which is interesting, if you go back to minoxidil, I remember back in the mid-80s, and I went to a conference in San Francisco, and everybody was saying minoxidil reverses male pattern baldness. So I said, well, there's 7,000 bald dermatologists in the audience. Why aren't they all grown hair? And what that was saying is that while you might not be, well, you're not with minoxidil controlling the genetic expression, you are in fact improving hair growth. So improving hair growth is an objective that the patient wants. Telling them that you're actually preventing their balding from developing is not quite truth. So we need an understanding that the patients will like hair growth, but you have to tell them the proper story.
May I interfere, you?
Yeah, absolutely.
Okay. So I would like to come back to Jill's and Hubert's intervention. If you show that a regressive disorder does not regress any longer, it's one part of information, and therefore you need accurate methodology. Even if you revert the balding process and you have excellent scalp coverage, then you enter into the subjective dimension of this patient. What was he dreaming of at the beginning of the trial? And he may be annoyed he has to rub in some lotion every day, and he may be annoyed by taking a pill every day, and even without any other side effect, he feels your excellent objective response is just peanuts. He's subjectively unhappy about the results. So we really have to consider accuracy, cost that is being involved, time that it requires, and also at the beginning, what is it that the patient expects? And we need during that consultation explain that if the process is not regressing anymore during the next 2 years, we have already achieved something very positive. But this is working with humans. Humans are a difficult animal.
And so far in androgenetic alopecia, it seems that only Jean can make patient really happy.
Well, the objective is to make no further progress. But actually, if you get the paper from experimental dermatology, there is some data there showing that we've reversed the process, not the miniaturization, but the balding process. And we've got patients going back 20 years who've got more hair than they had when they started in 94. And that's a combination of an anti-androgen topically together with finasteride. And we have some good data on that. But you know, it's one of these things, you can't recover hairs past a certain point. And people are quite happy saying, I'm happy with what I've got. Surgery helps, there's no question. And coming back to some of the issues which the techniques can use, surgery can complement the medical treatments, which do improve things. And it's a whole gamut of important things for the patient who thinks it's better. It's when perhaps unethically, some people claim that they can regrow hair where they can't, and they get people to spend money and they don't have any evidence. I mean, evidence-based medicine is really where we are. But, you know, we're in a world where sometimes people basically don't care about what the patient thinks and don't care about taking money from them and promising them various things. And hopefully, you know, with an ethical hair research community, we can get treatments which are working and are not promising more than they can deliver. And it's the same with hair transplant. You know, you've got to manage the expectation. You can have the best surgeons in the world. And if the patient thinks they're going to look like Tina Turner from nothing, they're not going to be happy, no matter how good the surgeon is. So balancing expectations, which is as Dominic said, you get somebody you can stop or the progression, it's an achievement. I mean, back in the 80s when we didn't have finasteride and various other things, you know, we could grow hair using oral medroxyprogesterone acetate, but you couldn't use it indefinitely. We only did it for a year and we regrow hair. We didn't convert the vellus hairs, but we actually prevented it from going forward. And I remember sending the paper to the JID and they thought we're a bunch of idiots and we should be struck off. And for the first time in 1986, we'd actually reversed male pattern hair loss. We didn't convert the vellus hairs, but we didn't know that at that time, but we actually did grow hair. And we had controls, we had untreated controls over the same period. But it was possible, but that was all oral hormonal manipulation, which we weren't advocating. We wanted to know, is it worthwhile spending time developing topical things or other things without oral medication? And here we are today. You know, we do have effective treatments, and it's very encouraging that things are moving forward and hopefully can reverse the miniaturized hair if we can get down to knowing what's going on there. So there you are, you've had 50-year history there, what we've been doing. I think Dominic and I met in 86. I can't remember when we met. Dominic will tell you. I did tell him that he wasn't doing things properly at the time. Right.
So I'm gonna have to go now, I'm afraid. So it's been really, really fascinating to have the discussion, and thanks again to the journal for organising it and Dominique for doing all his hard work. And hopefully we'll have many more discussions in person, Dominique.
Yeah, thank you.
Once we're let out from the pandemic.
Maybe
so it's been really, really good.
Yeah, maybe we have to give the word again to Professor Young to conclude the meeting. Don't you think so, Hugh?
Yeah, thank you.